So with that, I'd like to welcome Larry Singerman, who will moderate the very first session in the program today. Thank you, Larry.
Thank you, Barbara. This session is all updates on the treatments of new things, and all four speakers are experts on the things they're going to talk about. We're going to start with Jennifer Sun giving an update on the treatment of diabetic macular edema.
Thank you so much, Larry. And thank you to the Program Selection Committee for the opportunity to kick off this new session, which is very exciting. I'll be talking about an update on the treatment of diabetic macular edema. Here are my financial disclosures. So diabetic macular edema, or DME, as we know, is swelling of the central, visually important retina. And it results from abnormal vascular permeability. It is the most common cause of moderate vision loss in our patients with diabetes. And we're fortunate in that we've had excellent randomized controlled trials to guide us with level 1 evidence in terms of treatment of diabetic macular edema. I'll walk through just a few of those pieces of evidence. Many of them have come from DRCR Retina Network studies. Protocol I was the first phase 3 trial of anti-VEGF for DME, and you can see here the dramatically improved visual gains in the first year of treatment with ranibizumab as compared to the standard of care at the time, which was macular laser. Those vision gains were maintained throughout the 5 years of the study in the anti-VEGF treated groups, and yet the need for injections decreased dramatically over 5 years, to the point where many of our patients were able to get off of injections in years 4 and 5 of the study. The subsequent DRCR Protocol T showed us that baseline vision can influence the anti-VEGF treatment response. In eyes with just moderately impaired vision of 2032 to 2040, all three agents looked at in that study, aflibercept, bevacizumab, and ranibizumab, when given as monotherapy, performed similarly with vision gains. When we looked at eyes with worse visual acuity, 20/50 or worse, we saw that aflibercept-treated eyes in orange gained substantially more and significantly more vision than eyes treated with bevacizumab in green. And yet, although aflibercept monotherapy is clearly superior to bevacizumab monotherapy for DME, we subsequently saw that when you start with the strategy of treating with bevacizumab first and rescuing eyes with aflibercept, if the vision is not improving enough, those eyes do very well. Protocol AC did not see a difference between visual outcomes in eyes treated with aflibercept monotherapy versus a bevacizumab first strategy. And finally, when we look at eyes with good vision despite DME, 20/25 or better, we saw in Protocol V that eyes randomized to immediate aflibercept versus those treated with laser versus those that were observed and only treated if the vision worsened, all did very, very well. The median vision in each of these groups at 2 years was 20/20, and as you can see from this graph, 84 to 86% of all these groups had vision of 20/25 or better at the end of the study. So here's just a quick summary of our evidence-based care for DME, again, focused mostly on DRCR Retina Network studies, but of course there are many other pivotal trials and other studies that have given us excellent evidence. Anti-VEGF is first-line therapy for most eyes with center-involved DME. Our treatment approach can be guided by the baseline vision. In eyes with severe visual impairment, 20/50 or worse, aflibercept monotherapy is superior to bevacizumab, and yet a strategy of starting with bevacizumab first with aflibercept as needed for suboptimal improvement provides similar visual outcomes than just starting straight with aflibercept. In eyes with just moderate visual impairment, 2032 to 2040, aflibercept, bevacizumab, and ranibizumab monotherapy all result in similar vision gains. And in eyes with good vision, 20/25 or better, initial observation is a very reasonable strategy as long as you're following those eyes closely and giving anti-VEGF if there's vision worsening during follow-up. Finally, although I haven't shown that data, we've got many studies that suggest that steroids and macular laser still have a role for selected eyes with DME, although these therapies are usually used as adjunctive or second-line treatments. So what are available agents for diabetic macular edema? Well, here they are listed. The majority of them have been FDA approved specifically for DME. Bevacizumab and the Susvimo implant have not been approved. And we know that over the last 10 to 12 years, we've added multiple tools to our armamentarium for DME treatment. I'll point out that in the last 2 years, we've seen an explosion of approvals for biosimilars with reference agents to ranibizumab or aflibercept, and there have been 5 approvals for aflibercept biosimilars in the last year alone. And I know Neil Bressler is going to be talking about the biosimilar use tomorrow, I think. So what have we learned from the more recent pivotal trials in DME? Well, I'll focus on faricimab and aflibercept 8 milligrams because I think those are the two that are probably most commonly used in our clinics. When we look at the phase 3 trials, Yosemite and Rhine, and the open label extension, RHONE-X, as well as the PHOTON study, we see that both of these agents result in very similar visual acuity gains when we compare them to control arms of aflibercept 2 milligrams given on a Q8-week schedule. There is extended dosing that may be a potential advantage of these newer agents. In fact, when we look at the RHONE-X data, approximately 80%, nearly 80% of patients were on Q12 to Q16 week dosing by the end of 4 years of treatment with faricimab. When we look at the PHOTON data at 96 weeks, nearly 90% of patients had maintained their randomized intervals of Q12 or Q16 weeks at that time point. And yet I'll point out that there are no recent head-to-head comparative effectiveness studies of anti-VEGF agents for DME. And the pivotal trials have not used identical dosing regimens for their treatment and control arms. So we still don't have conclusive evidence about what the extended dosing might be for individual agents, and yet the data is promising. I'll also point out that minority populations, in a limitation of our studies, are frequently underrepresented in our clinical trials for FDA-approved ophthalmology therapies. We're looking forward to hearing the first-time results from the Elevatum study, which is a phase 4 multi-center open-label single-arm study of faricimab for DME that enrolled underrepresented populations, and we'll be hearing that later today. So what's been happening over the last year or two? Barb asked, what's new? Well, in the last 2 years, we've seen 16 completed phase 1 to 4 clinical studies. And in fact, we'll be hearing the results of the Wnt agonist Restoret later today, the phase 1-2 study that's there. I will also say that there are 87 active clinical trials for DME listed on clinicaltrials.gov as of yesterday. And so we've got very active pipelines of studies that are recruited and in follow-up, that are currently recruiting, and that are not yet recruiting. And this list is too long to go through individually, but I'll point out that we see a lot of studies looking at alternative pathways to anti-VEGF, which is exciting, and many studies are looking at alternative dosing routes, as well as oral and eye drops, as well as gene therapy that might offer extended dosing. So I'll conclude by just saying our current treatment of DME is guided by evidence from multiple randomized controlled trials. It's told us when to treat, how to treat, and which agents to use. Compared to a decade ago, the more recently approved anti-VEGF therapies appear to offer similar visual gains with the potential for extended dosing. And there's a very active pipeline for potential new therapeutics for DME, looking at alternative mechanisms and a variety of delivery routes and durability. So we look forward to more data, more discussions, and more discoveries in DME, and thank you very much.
Thank you, Jennifer. Next, Michael Ip will give us an update on the current treatment of diabetic retinopathy.
Thank you, Dr. Singerman, for the introduction. It's a pleasure to present this update. My disclosures can be seen here on this slide. So the current options for the treatment of non-proliferative diabetic retinopathy in the absence of diabetic macular edema that are currently FDA approved include reference ranibizumab, one ranibizumab biosimilar, reference 2 milligram aflibercept along with 3 aflibercept biosimilars, as well as 8 milligram aflibercept. Interestingly, these labels do not provide any guidance on what level of diabetic retinopathy to treat, nor how to treat such eyes. There is strong evidence in support of the treatment in this indication. Based largely on a secondary analysis, you can see here that both doses of ranibizumab had a higher proportion of a 2 or more step or a 3 or more step improvement in retinopathy severity score compared with sham-treated eyes, leading to the FDA approval of ranibizumab for this indication. The Panorama clinical trial looked directly at this indication and found that the proportion of patients with a 2 or more step improvement from baseline to 1 year in DRSS was greater in both aflibercept regimens compared with the sham, leading to FDA approval of this molecule. The PHOTON clinical trial was primarily a DME clinical trial and looked at a secondary outcome of DRSS score, and based on the non-inferiority of the 8Q12 to the 2Q8, as well as the fact that 8 milligram aflibercept is not a new molecular entity compared with 2 milligram aflibercept, it was FDA approved. So which subgroup of eyes, now that we have these treatments available with NPDR, may benefit the most? Well, there was one analysis from RIDE and RISE that showed that eyes with a moderately severe or severe NPDR, so-called level 47 and 53, had the greatest treatment benefit. Complementary analysis here showed, from RIDE showed that the eyes that were untreated in the fellow eye group had the most progression without treatment. So the paradigm really is to consider treatment of highest risk eyes. These eyes are the ones that are most likely to have retinopathy level regression with anti-VEGF therapy and are the ones that are most likely to progress without treatment. In 2017, the AAO published a preferred practice pattern, which was updated in 2023, as shown here, which indicates that eyes with severe NPDR can sometimes be considered for intravitreal anti-VEGF therapy. There was an IRIS registry study that also provided additional evidence where they looked at newly diagnosed diabetic retinopathy eyes with good visual acuity, and they had an evaluable subset of over 53,000 eyes, where they showed that in these eyes with good vision, the more advanced the DR stage at baseline, the greater risk of developing sustained blindness, suggesting that we need to do a better job of screening such eyes, and when we do find these eyes, that perhaps earlier intervention is going to be beneficial. However, there is evidence suggesting against the treatment of NPDR in this indication. The best known example is DRCR-NET Protocol W, where eyes were randomized between a treatment strategy of aflibercept versus sham injection. And this slide shows the main result, where although the aflibercept-treated eyes had a lower incidence of developing vision-threatening complications over the 4-year period of time, the visual acuity was similar at the end of 4 years, suggesting that aflibercept, as used as a treatment strategy in Protocol W, may not be warranted. Roger Goldberg and colleagues introduced this concept of induced versus native retinopathy, suggesting that even though phenotypically they look similar, they may behave differently. They looked at eyes with DRSS greater than 43 at baseline who improved to a DRSS of less than 43 at the end of RIDE and RISE at the end of 3 years. Followed them out for an additional 1 year in the open label extension study, and you can see on the left-hand side of the screen, these induced eyes progressed a mean of 1 level of retinopathy, whereas in contrast, the eyes that were natively at less than or equal to 43 were followed for an additional year in RIDE and RISE without any treatment, and you can see on the right-hand side of the screen that these eyes had no difference in their retinopathy severity score, indicating that these eyes behave quite differently. The last time this question was asked in the ASRS PAT survey was 2023, and you can see here on this slide that over 50% of US respondents and over 60% of international respondents will not treat this indication. And so there are a number of treatment approaches that might change the needle in the future, similar to what Jenny just showed with respect to DME. There's a wealth of activity regarding different MOAs and different molecules looking at the treatment of non-proliferative diabetic retinopathy, and more will be discussed tomorrow in the diabetic retinopathy session regarding specifics of these approaches. So in conclusion, there is strong evidence of a treatment effect with anti-VEGF therapy, specifically from a number of randomized controlled clinical trials. It appears that eyes with the highest risk NPDR may benefit the most. There is evidence from a database study that the more advanced the DR stage at baseline, the greater the risk of developing sustained blindness. However, DRCR-NET Protocol W suggests that aflibercept as a preventative strategy may not be generally warranted in the setting of NPDR without DME. And again, this concept of induced retinopathy, where they phenotypically look similar to native eyes, where they behave differently, might give us pause to treat this indication. And then I think that the widespread adoption of the treatment of NPDR without DME will depend on new molecules and drugs and approaches with a similar or better efficacy profile, a similar safety profile, and certainly with a reduced treatment burden. Thank you.
Thank you, Michael. Next, Dan Martin will present an update on the treatment of AMD, small topic.
Thank you, Larry. Thank you. I have no financial interest to disclose. So over the last 20 years, we've had a steady succession of new drugs become available to us to treat neovascular AMD, the two newest being faricimab and aflibercept HD. There's been much discussion about the relative differences between these drugs, but it may surprise you to find out that, in fact, there are no randomized clinical trials that have ever shown a visual acuity outcome difference between any of these drugs. In the 6 trials that compared bevacizumab and ranibizumab, including CAT and IVAN, there was no difference in visual acuity between either drug at 1 and 2 years. In View 1, View 2, which compared ranibizumab to aflibercept, no difference at 1 and 2 years. In Hawk and Harrier, that compared brolucizumab to aflibercept, no difference in visual acuity between 1 and 2 years. In Tenaya and Lucerne, that compared faricimab to Eylea 2 milligrams, no difference in 1 and 2 years in visual acuity. And in Pulsar, 8 milligrams versus 2 milligrams of aflibercept, no difference in visual acuity at 1 and 2 years. So if there's no difference in visual outcomes, what advantages do these newer drugs offer us? Well, it's really what we've been looking for, a greater ability to reduce or eliminate fluid. And in fact, both drugs, faricimab and aflibercept HD, appear to do that, and that's visible in all of the clinical trials. There also appears to be increased durability with reduced treatment burden. In Tenaya and Lucerne, similar to what Jenny just showed for DME, 80% of patients were able to be dosed every 12 or 16 weeks, with almost half of patients being able to be dosed at 48 weeks every 16 weeks. And in Pulsar for for aflibercept 8 milligrams, 78% of patients were able to be dosed every 16 weeks at week 96. So what we still need to know, though, is that what is the true durability of faricimab and aflibercept HD in standard clinical practice? These randomized clinical trials, which are beautifully executed, but the reality is they tolerated more fluid than most clinicians do in practice. The assessment of disease activity in the randomized clinical trials was less than in clinical practice sometimes, and particularly in the second year of the studies. The drug dosing in these trials generally is not what we use in clinical practice. It's most commonly what we use to treat and extend with zero tolerance to fluid. And you also need to realize that any assessment of durability is confounded in any fixed dosing regimen because eyes naturally have a reduced dosing schedule some of the time. In CAT, 1 in 7 patients required only 3 injections. In these trials, there's no control for you to be able to figure out how much the durability is due to the drug versus how much was occurring naturally. We'd also like to know, is one drug more effective or more durable than the other? The DRCR Retina Network has been approached multiple times to do a head-to-head trial. We're not going to do that. Visual acuity will almost certainly have to be the primary, and as I just showed you, every clinical trial that's compared any 2 drugs has never shown a difference. I think we probably already know what the result would be. In geographic atrophy, what's new? Well, there's a lot. Over the last, in 2023, we had approval of pegcetacoplan and avacincaptad. Both drugs showed I'll be kind, modest improvement or reduction in geographic atrophy growth. For pegcetacoplan, unfortunately, there was no visual acuity correlate. There was no difference in visual acuity between treated and untreated patients. For avacincaptad, a similar level of reduction in geographic atrophy growth, but no difference in visual acuity at 12 months, although in a post-hoc analysis, there was the portion of patients who lost 15 letters at 2 consecutive visits, there was a statistically significant benefit in the direction of ACP. The side effects have been fascinating with these drugs. The conversion to neovascular AMD, to me, is probably the most interesting part of all these trials. Why does this happen? We saw a 4-fold increase conversion in the pegcetacoplan eyes, a 2-fold increase conversion in the avacincaptad eyes. There's also intraocular inflammation with pegcetacoplan, ischemic optic neuropathy, and of course the severe occlusive retinal vasculitis cases really gave us pause. Many of you've seen these photographs. If you've ever seen these patients in person, it'll really give you pause. Happily, this is an infrequent event. Some of these eyes go to NLP and enucleation after a single injection, but happily that's only a less than 1 in 10,000 event. Retinal vasculitis probably about 1 in 4,000. The uptake in the retina community has been fascinating with these drugs. Most large academic medical centers use these drugs, if not at all, sparingly. And in fact, when you look at the ASRS PAT survey, 77% of physicians do not treat or treat less than 10% of their geographic atrophy patients. So why weren't these drugs more effective for GA and visual acuity? It's really sort of interesting to think about. First, it's not clear how important of a role complement plays in geographic atrophy progression. There may be more to the story. We may be intervening too late in the disease. The results, remember, are expressed for the entire cohort when it's known there is considerable variability in the rates of growth. To me, this is the most promising aspect of these drugs, perhaps we'll be able to prospectively identify groups who are more responsive to treatment. And it's pretty clear that trials need to be longer to demonstrate how effective these drugs may be. The GALE study, which is the extension of the pegcetacoplan, suggests that this may indeed be the case. So what's coming? In 2024, home OCT was approved by the FDA. The DRCR Retina Network launched Protocol AO to help us understand how to use this device. It's a 600 eyes with newly diagnosed neovascular AMD who are randomly assigned to home OCT-guided treatment versus treat and extend. The feasibility study showed us a fascinating variability and treatment response curves. And when you think about superimposing a sort of one-size-fits-all onto that, it makes you realize there's a lot of opportunity for improvement. And finally, there are a number of AMD drugs who've entered phase 3 clinical trials, 2 tyrosine kinase inhibitors, 1 anti-VEGF-C and D, gene therapy, and the return to the port delivery system. So we have a lot to look forward to in 2025. Thank you very much.
Dan, thanks very much for that. Was a lot of material to cover, and it was done very well. The next talk will be by Tim Murray, an update on the treatment of tumors.
I'd like to thank the organizing committee and Dr. Singerman for the opportunity to speak with you, and we have an excellent program in Chicago. I have no relevant disclosures for this talk, but much of what we'll discuss is going to be the off-label use of drugs and devices. I'm going to focus on 5 major advances in the field of ocular oncology. Number one is that enucleation for tumor treatment is now rarely a primary therapy for the 2 most common cancers, retinoblastoma and melanoma. And why has that happened? It's happened because we have advances in delivery of chemotherapy in retinoblastoma that include intraarterial and intravitreal chemotherapy. And for melanoma, we're improving diagnostic accuracy and shifting to earlier treatment for our patients, and we've had the ability to couple these therapies with anti-VEGF. This is the ultimate fluorescein angiography. This is intraarterial chemo in a 2-year-old who has bilateral disease. This is the worst eye, and this led to recovery of the eye and stabilization of the vision without requiring enucleation, utilizing intraarterial chemotherapy coupled with direct laser ablation. This looks at decades of time over a 30-year period, showing the primary enucleation rates for advanced retinoblastoma. And you can see now that primary retinoblastoma enucleation is approximately 1 in 20 patients. Melanoma, the gold standard when we started with this was enucleation. We shifted to radiotherapy, either charged particle or brachytherapy, and then we've moved to non-radiotherapeutic procedures for small tumors. But these tumor treatments are critical. What has happened, though, is that enucleation now is rarely the first approach to management for melanoma. What's our second major advance? It is the shift to radiotherapy. So the use of brachytherapy or charged particle for virtually all medium and large uveal melanomas, whether juxtapapillary or not. And it's important to recognize that tumor control rates for these diseases approximate 99% over a 5-year window. And that's because we have improvements in our radiotherapy delivery and our localization techniques. We've now coupled radiotherapy with fine needle aspiration biopsy, and that biopsy also is going to be shown to be incredibly effective in both medium, large, and small tumors. Iodine 125 brachytherapy is my treatment of choice for these. You can see we do tumor localization. Here's the standardized plaque configuration. As you can see, I'm a fast surgeon like all of you in this room. So we localize, we place the plaque is sutured into position, we confirm the placement with intraoperative ultrasound, we perform fine needle aspiration biopsy for molecular genomics, the patient leaves the operating room, and for me, the plaque stays in place for a 72-hour period and then is removed in a short intraoperative procedure. This is the intraoperative localization with ultrasound that we think is so critical, especially for those of us that are newer to plaque brachytherapy or have tumors that are posteriorly located. And you can see that we have an excellent ability to show plaque localization and centration around the tumor in a very short intraoperative review with ultrasound. Now, advance 3, fine needle aspiration biopsy. For me, we have to thank Bill Harbour and his team and the Shields for the cytogenetics progression, but fine needle aspiration biopsy is effective for all tumor sizes. It's important to recognize that we can biopsy small, medium, and large tumors. This allows the gene expression profiling that gives us prognostication for our patients, and this is accurate in 99% of all tumors biopsied. Why is that important? So the Class 1A GEP has a 2% mortality rate at 5 years, 1B has a 21% mortality rate at 5 years, and Class 2 has a 72% mortality. Why do I stress that? Because Class 2 small tumors at 5 years undergoing ablation have a 4% metastatic rate. So we're able to move a Class 2 tumor by early treatment from a 72% mortality to a 4% mortality, which is the single greatest impact in outcomes for our patients in the last two decades. This is a 72-year-old Latin woman with 20/25 visual acuity. Her tumor increased to 2.3 millimeters in apical height with increasing orange pigment and subretinal fluid. She went ablation surgery, which we've discussed here prior, with biopsy. She has a Class 2 tumor, and 5 years after treatment, she's 20/25, alive and well without metastatic disease. Our last advance is the use of anti-VEGF therapy to treat both radiation and tumor retinopathy. The take-home message from the collaborative ocular melanoma study was that at 36 months, mean vision was 2300. With the use of aggressive anti-VEGF, typically every 6 weeks, either at the start of brachytherapy or awaiting the complication of radiation retinopathy, vision is improved to 20/42 for that series at 5 years. So in conclusion, ocular oncology and your retina practice has experienced major advancements over the last decade. Earlier diagnosis utilizing advanced imaging has allowed earlier treatment, which has allowed our patients to live longer, healthier eyes, maintain their globes with excellent visual acuity and function. Tumor genetics continue to play a major role, and we'll discuss going forward the impact in our ocular oncology session. Thank you.
Thank you, Tim, and I want to thank all the speakers for their really excellent talks, but also remarkably, they were all on time.